So as one of our fellows said to me on a chat this morning, we're bringing the heat today. I think this is going to be a really incredible talk, and I want to introduce our esteemed speaker, Dr. Jonathan Mermin, MD and PH, who's the director of the National Center for HIV, Viral Hepatitis, STD, and TB Prevention. And he's a retired two-star Rear Admiral in the U.S. Public Health Service. He leads the nation's efforts to prevent HIV, viral hepatitis, STIs, and tuberculosis. These infections affect millions of Americans and cause tens of thousands of deaths each year. And the organization focuses on high impact prevention strategies that are cost effective, scalable, and grounded in the latest research. Dr. Mermin served as the incident manager for CDC's Mpox response for 6 months, where he led the agency's efforts to bring accurate information, testing, vaccination, and treatment to communities affected by Mpox and worked to decrease health inequities associated with the virus. In 2021, during the COVID-19 pandemic, he served for several months as acting director of the Center for Preparedness and Response. From 2009 to 2013, Dr. Mermin directed the CDC's Division of HIV Prevention, during which time HIV incidence decreased in the US, due in part to CDC focusing on more effective interventions and distributing resources based on HIV epidemiology. He previously served as the director of CDC Kenya and HHS Public Health Attaché for the U.S. Embassy from 2006 to 2009, and as the director of CDC Uganda from 1999 to 2006. In Uganda, he oversaw implementation of the first antiretroviral treatment program funded by the CDC outside of the U.S. He began his career at the CDC in 1995 as an EIS officer with the Foodborne and Diarrheal Disease Branch. He completed an internal medicine residency at San Francisco General Hospital and a preventative medicine residency at CDC and the California Department of Health Services. He's a graduate of Harvard College and Stanford University School of Medicine, received his MPH from Emory. He has co-authored more than 200 scientific articles. He currently serves as adjunct professor at Emory University School of Public Health. So we are so excited to have you. I still don't see slides, though.
Well, so right, so this is the problem. Even though you were kind enough to read that incredibly long bio, I still may not be able to share my slides. So let me see if this works.
I found them.
He got them.
You did?
I've received them just now.
All right, let's pop
that would be great.
And I was just, it sounds like Dr. Mermin is very open to being interrupted. I think we still want to respect him and his presentation. So interruptions for clarifications. And he said that this is a relatively short presentation, so we should have a lot of time for discussion at the end. And with that, I will turn it over to you as soon as Marvin puts it into presenter mode.
Yeah.
Nope. What? It's like we've never done this before.
It's working.
Wonderful.
Excellent. No, thank you very much. And I will say that I have deep respect for this group because you were persistent. You reached out like 2 years ago, and somehow I've been elusive. But I really had I really looked forward to engaging. I'd hoped initially to come out personally and then also see some of the programs and activities in San Diego and UCSD. There's some great stuff, and couldn't do that. So I appreciate the option to do it virtually. But I'm going to talk a bit about how some of the science and law are interacting about HIV criminalization laws, and really just highlighting the fact that public health is inherently political, but it doesn't have to be partisan, and that to make a difference, sometimes you want to use laws or policies because they can last a long time and often work with the social and economic determinants of health in a way that individual care or policies or programs can't. But at the same time, sometimes you need to actually change or withdraw laws that are causing harm. So that's part of what this started many years ago when some people in the HIV activist community had come to me and talked about how these laws were causing distress and potential harm, and they wanted us to change them. And so we ended up working with the Department of Justice, and it kind of moved forward both some scientific analyses as well as some policy change. So next slide, please, Marvin. So what I wanted to start off with is just a little bit of a brief background on what's going on right now Oh, I guess, yeah, I'll skip the objectives, and I have no disclosures. I work for the federal government. Just to talk a little bit about so I'm going to learn the current state of HIV in the US, just kind of overview of epidemiology. Happy to talk more about what's going on, understand the history and the application of these specific laws, and then learn about some of the efforts to change them. Next slide. Thanks. Next. So on the left here, showing what's happening to HIV incidence, essentially defined as the number of cases, rather than a rate, just because it's easier to kind of, I don't know, interpret what's happening. But we starting in about 2010, we started to see declines in HIV for about 5 years, and that coincided with several different kind of efforts. One was redistribution of CDC's resources to health departments. We give about $450 million a year out to health departments, and they hadn't been kind of aligned with the epidemic previously as much. So there had been kind of time where, for a variety of reasons, different jurisdictions were getting more money, even though a state like Florida had many more cases in the prior year than they had 10 years ago or 15 years ago. So we redistributed money, and there have been studies actually that show that where CDC or HIV money goes is actually associated with reduced incidence. It's nice to know that kind of you make a difference. But we also started to focus more on biomedical interventions, particularly antiretroviral therapy and getting people diagnosed. And so a higher proportion of people in the United States know their status than did 15 or 20 years ago. And that allowed a better prevention to occur. After that first shift of 5 years, which didn't really see increased money, just kind of better work and a better distribution of resources, we kind of stalled for a while. And then starting in 2017, we started to see fairly consistent declines, including into 2021. And I will just say that this month we'll be putting out 2022 data, and that is consistent with, again, small decreases in the absolute number of cases every year, much slower than we would have wanted, but consistent with decreases. And I will say what that's been associated with is not only preventing HIV infections, but calculations from economists have shown that really, truly tens of billions of dollars are saved, because the lifetime costs of HIV are about $500,000 for healthcare. So it's helpful to prevent infections, and most good HIV prevention is cost saving. On the right, we're just showing increasing HIV prevalence. And you can see that in 2010, there were about 985,000 people living with HIV. It's now about 1.2 million. And that increase which is consistent with increases since 1996, really has coincided with the introduction of triple therapy. And that we saw 80% reduction in mortality between 1995 and 1997, and people with HIV. It was a remarkable change where physicians adopted, HAART very, very quickly, and consistently we're doing better and better. So, so our most recent data show under 10,000 people die of HIV infection every year, of these 1.2 million people. But a higher proportion die with HIV infection. It's just not the cause of their death. And ideally, that's where we would end up, that we would reduce incidence so much that it's below the number of people who die with HIV, and ultimately prevalence will go down. We're not there yet, and there are only a few countries in the world that have reached that kind of milestone. But there are a lot of people with HIV in the nation, and we have an obligation to provide them with good healthcare and appropriate social services. Next slide, please. This slide just highlights that the incidence trends really do vary across cities and states, that you can do a better job or a worse job. And I added in San Diego County because I thought you guys would care, but you guys are doing well. Like, you have a 4.7% reduction. California as a whole is a 13%. I don't know if I should blame you for that, but you have places like Oregon, which are going up, Arkansas, which are going up. Some of it is varying. There are varying reasons why this is occurring, but it is true that the states that end up putting money for HIV prevention and services of their own revenue and tend to do better for HIV than those states that rely solely on federal resources. Next slide. And then I just wanted to highlight here that because it's very much relates to thinking about HIV criminalization laws, which is that HIV does affect everyone, but it's fundamentally not equal. So these bars are just data from 2021 that is showing, among who exactly gets HIV, I would say that I don't know of a single health disparity that is greater than HIV among gay and bisexual men and transgender women. They're 100 times more likely to get HIV than heterosexual men and women. And about 70% of new HIV infections every year in this population. We can talk about why that is. It's primarily because receptive anal sex is 18 times riskier than receptive vaginal sex, because once there's a high prevalence of people, and associated with people with a detectable viral load, you're every time you have sex, you have a much higher risk of getting HIV than if you're in a low prevalence population. And also it's harder to get access to some services because of kind of systemic homophobia and some racism that's still in existence. So we are seeing that happening. And I will say that it also provides an opportunity to, if you focus your resources among the populations the most affected, then you can see reductions. And that's what's happened in a lot of those cities and states in the map, is they've said, we're going to make sure that people have access to testing and treatment and PrEP and other prevention, and that's made a big difference. We have had persistent racial and ethnic disparities as well in the US. African Americans are 8 times and Latinos are 3 times more likely to have HIV than white Americans. Asians have the lowest rate. That really, that hasn't changed very much over time, although it's a little bit, it's gotten somewhat better. But I would say that among some populations it's changed. So for example, among women with HIV, incidence has decreased much faster among African Americans than among whites. And I think I have that slide on that. If I can go to the next slide. Yeah, so you can see that the yellow line is African American women and HIV diagnoses. The other 2 lines are Hispanic and white women. And you can see there's still a persistent disparity. The dip in 2020 is due to diagnosis this being harder during the COVID epidemic. But you can see it went back up to kind of the same trend. But some of this is really persistent efforts by the community and to be able to make sure the testing was available and that treatment was available to populations that had a harder time accessing treatment previously. Next slide. And this slide is I have 4 different figures here. This is just estimated incidence among MSM, and things have been changing over time. So on the left, you can see that by age, you can see that in 2010, the population of African American MSM with the highest rate, the highest number of HIV new infections were below the age of 24. And it was almost 5,000 of the, at that point, I guess, 40,000 cases in the United States. What you can see is that's had a pretty steady decrease. And that really was one of the most profound differences that we've seen in reducing disparities in HIV. And a lot of it was response from the Black gay community saying that this is unacceptable and really ensuring that at that point, diagnosis and treatment were available to people and that they got access to Ryan White services and were able to actually decrease incidence. You can see that the incidence kind of somewhat increased among people between 25 and 34 and was relatively stable with some decreases in other ages. That trend seems to be kind of repeated itself with some modification in the other race and ethnicities. And I'd like to say that what happens is that it's just to be able to start decreasing incidence, you need to have higher coverage of services when there's a very high incidence rate. And so if you look at Hispanic and Latinos, we see increases actually up until fairly recently among the 25 to 34-year-olds, the same group that saw some smaller increases among African Americans. We saw decreases also among 13 to 24-year-olds. And then among whites, you end up seeing decreases among pretty much everybody, but although there's a little bit of stability in the 25 to 34-year-olds more recently. So everyone's not the same. All communities are not the same. Sexual networks cross race and ethnicity as well as kind of transmission categories. But what we're seeing is that young MSM, and I would say this is also occurring in heterosexuals, and even people who inject drugs, that we're seeing the under the age of 25, we're seeing some success in being able to decrease HIV incidence regardless of population. It's much harder in 25 to 34-year-olds. And that really is the group bearing the brunt of new incidents these days. And so there's a lot of effort to try to focus efforts there. Next slide, please. And then I just wanted to highlight that it's not an insurmountable problem. We did a calculation by county, just looking at which counties, if we kind of added up the number of new diagnoses. And this is old data. We use this to kind of create a new initiative for HIV prevention and treatment. And what we did is it looked like 50% of all the new HIV diagnoses occurred in only 48 counties, plus Washington, D.C. and San Juan, Puerto Rico. So essentially 50 local jurisdictions had 50% of all new HIV diagnoses. And that's out of 3,300 counties in America. So it's not everywhere that has the major problem. Now, this is number. So counties that have more people are going to be also having more HIV. But it's also, you can realize it suddenly becomes more tenable to try to make a difference if you realize it's not all of my state, or even within counties, all of my county that needs to, to put into place routine HIV screening in my hospital, or ensure that PrEP is available in your STI clinic. Next slide, please. And then if this slide just shows what happens if you try to get 75% of the diagnoses, and that is 148 counties, still not that many compared to the 3,300, but it starts spreading. And then if I can ask for the next slide, that's showing about 90. So once you go to 90% of new HIV diagnoses, you're really at a third of all counties, and you really are starting to spread out. So to make a big difference, we need to focus efforts on the counties that are most affected and the areas most affected and the populations most affected. But to truly reduce HIV to the levels that we want to, we're going to need to ensure that services are at least available for people who need them in many different areas of the country. Next slide. And so this one I just wanted to show. I just thought you guys are in California. I have to present something on California. So this is just the last 4 years of kind of the different indicators. So yellow is linkage to care, and linkage to care within the 30 days following diagnosis is really up into the 80% mark for California. Knowledge of status is also about 84%, and viral suppression rates are also fairly stable over time. So essentially in the US and California are kind of matching each other to some extent, with California being maybe a little bit better in some of the indicators. But there's a challenge for all of us to kind of keep these improving over time. Next slide. And then this is just some other last data on what's happening with the epidemic. So as I think I showed, we've had about a 12% reduction in HIV incidence between 2017 and 2021. And we're hoping to continue that trend over time. 2 years ago, when we were able to calculate the latest data, about 87% of people with HIV know their status. That means there's about 160,000 people who don't. And really trying to get testing to people who aren't being tested either regularly enough or not being tested at all is a critical component of our public health efforts. PrEP coverage has expanded tremendously. I would say it took a long time to get started. But we're now at about 30% of people we estimate to be eligible for PrEP have received a prescription. That's not dealing with the complex issues of, you got a prescription, did you take it? Did you get enough of it, the prescriptions? Did you get a refill? Am I still at risk? And even some other questions about how do we even determine the goal? Like, who is really eligible for PrEP and should be getting PrEP is still, I think, scientifically challenging. But the idea is at least the number of people who've gotten a prescription and who know about it is increasing. There are some major disparities there by race and ethnicity that a lot of people are concerned about. Viral suppression rates are slowly going up. And then the last I would just say is we can take some, I don't know, compliments about is perinatal transmission. The US met our goal of perinatal transmission elimination in 2018. And the most recent year, we only had 21 cases of perinatal transmission of HIV. So unlike congenital syphilis, which is going tremendously in the wrong direction, for HIV, we've really been able to do a very good job of preventing perinatal transmission. Next slide. Okay, so now laws. What's going on? Why are we having this talk in the first place? Next slide. So what I wanted to start off by that laws matter. So you know there's a lot of discussions about how do we make a difference in public health? How do we make a difference as clinicians? I wanted to highlight just a few areas where kind of major policies actually had an effect on HIV. So we actually did a randomized controlled trial with the HUD, which looked at giving housing to people with HIV. And what we found was being homeless was associated with the 2.5 higher odds of having a detectable viral load. And so essentially providing housing for people with HIV both improves their health care and also prevents transmission to others by helping them suppress their viral load. In addition, receiving Ryan White services is associated with a much higher rate of viral suppression, and patients in Ryan White are 5% more likely to be virally suppressed than those with private insurance. So these are people who are poor, the majority who are below the poverty level, and yet what we are seeing is that they actually do better because of a lot of the understanding about social determinants of health. And although the figure here is somewhat old, basically, Ryan White has been able to decrease the racial and ethnic disparities and other disparities that they've seen over time, so that everyone is kind of moving up now to a median viral suppression rate of about 89%. Next slide, please. Syringe service programs. So these are kind of policies. States and local jurisdictions can support syringe service programs in a variety of ways or make them illegal. But they have been associated with a 50% reduction in hepatitis C and HIV infection. Hepatitis C is 10 times more likely to be transmitted during sharing meals than HIV. So you'll always see it kind of presage HIV outbreaks among people who inject drugs. And when syringe service programs are combined with medication for opioid use disorder through linkage to care or directly at the facilities, the reductions are even greater. Also, clients who use SSPs in 2 studies are about 3 times more likely to stop injection because they're more likely to get linked to substance use treatment when they are ready for that. In addition, naloxone distribution through SSPs is associated with reduced overdose deaths. And these figures just show that the laws related to SSPs vary by state and local jurisdiction. And we have a website, as do others, that kind of highlight that it's kind of complex. It's not just are they legal or not. It's do they allow providing a certain number of syringes, or there restriction? Are there other restrictions on the practices that this syringe service program is using to support their clients? And so there's other areas that this comes up, but SSPs work, but they become somewhat politicized and kind of require care and nurturing to maintain them. Next slide. So, and then I also wanted to highlight other policies. So LGBTQ supportive policies also affect health. So sexual minorities who live in areas with the most structural LGBT stigma experience higher mortality than their heterosexual counterparts. And when you look at LGBT protective laws, they're associated with a 2 to 3% lower mortality among persons with HIV. And I'll say that even though there was a tendency over the past 10 years for greater support for LGBTQ persons, what we've seen is that's kind of either becoming limited or reversing. And I just put aside that there's now a lot of controversy in other countries, especially in Africa, where it's some draconian laws are being put into place in 33 countries in Africa. The worst is in Uganda, but they are not just harming people for general health, but specifically for HIV, where even in Africa, gay and bisexual and transgender persons are more likely to get HIV than the heterosexual population. Next slide. And then I just wanted to mention one other, so you can go really large scale if you want to deal with social determinants and laws, and things like Social Security, which was put into place because so many old people were dying or homeless in the United States, has been associated with large decreases in poverty and mortality. Medicaid expansion is associated with improved health outcomes related to HIV and cancer, maternal and neonatal health, reduced health disparities, and Medicare is associated with reduced mortality, hospitalization rates, and healthcare expenditure. So health insurance matters, and I think I'm talking to converted people here. And if physicians didn't have to spend all their time trying to deal with health insurance, you'd probably be able to enjoy your life better caring for patients. But it's just this is a big issue for us. But just to think about, sometimes that bigger picture can make it easier for us to do our jobs. Next slide. So now I wanted to talk about the specific laws related to HIV criminalization. Next slide, please. So what happened is states began passing laws that we call HIV criminalization laws in the 1980s, and they were essentially laws about HIV exposure. They're laws that said it should be a felony or legal if someone who knows they have HIV exposes someone to body fluids, either through sex or other means. And in 1990, to receive Ryan White resources, a state had to certify that their criminal laws were adequate to prosecute individuals who knowingly exposed others to HIV. So that there already were states that had laws in place related to HIV, kind of HIV exposure, but that particular requirement in 1990 increased the number even more. And they were kind of in place for a period of time, with wide variance in their use. But what happened is in 2010, a federal panel advised states to examine their laws and to improve them. We, as I said, worked with the Department of Justice, both on analyzing some data and then also them putting out guidance to attorneys general about how they should be able to look at their laws and try to revise them. And there's still ongoing efforts, particularly through the HIV activist community, to try to change both the laws themselves or eliminate them, or how they are being implemented. Next slide. So what's the deal with the content of these laws? So first, in 2014, when we looked at the laws and we published an article that said that even if you believe that these laws were put into place to protect the public's health, 30% of the state's laws include things that have been proven not to transmit HIV, like urine or exposure or spitting, and that's when the DOJ did issue a kind of a best practices guide. But you can see here on the right that sometimes the maximum sentence length for having met the criteria of these laws, it can be quite extensive. And there are people who are currently incarcerated because these laws have been applied to them, even when the laws are not associated. The exposure itself did not put someone at risk and certainly did not transmit HIV. Next slide. And then this just shows that there's a wide variance in these laws and how they're applied. You can see that in the kind of teal, we have criminalization or control actions through HIV specific statutes, and still in many different states. Some states criminalize potential exposure through their other communicable disease infectious laws. Some have sentence enhancement statutes, and then some states actually have no either no laws related to this, or they use general criminal statutes. So eliminating just the specific HIV criminalization laws may not actually eliminate the potential for prosecutors to be able to use other laws to prosecute people for potential exposures. Next slide. And so again, this kind of map is just which states started putting in laws. And sometimes states have actually adapted their laws. More recently, some states have actually withdrawn some laws or changed them. But you can see a lot of them occurred in the 1980s and 90s, associated with kind of that time when there was a lot more fear, less knowledge about how HIV was transmitted, and the federal government was requiring to receive Ryan White funds, you had to have some kind of laws in place. Next slide, please. And then I just wanted to highlight here, I like Marlene, she's drawing on our figures. This is just to remind us of how HIV is transmitted, and there's different rates of transmission by different exposures. So old studies have shown that if you receive a unit of blood from someone who has HIV and is, not virally suppressed, then there's a 93% transmission rate. So people, it's a lot of blood, that's a lot of virus, it's directly into your bloodstream, and it's highly likely that you will acquire HIV if you receive a blood transfusion. A percutaneous needle stick has about a 1 in 200, 1 in 180 chance of transmitting. So not as high. There are associated factors, like if it was from an artery versus a vein, if you had a deep puncture versus not a deep puncture, obviously if the person was on ART or not, but essentially it's a much reduced rate compared to a blood transfusion. Vaginal penile intercourse also has a much lower rate of transmission from that. It increases again with STIs, gonorrhea, chlamydia, syphilis, and herpes, all increase the possibility that you will transmit HIV or acquire HIV, but only by about doubling it. So each act is not very likely to transmit HIV. It's multiple acts that do over time. Oral sex has very rarely been associated with transmission. Almost always it's been with blood involved as well. But there have been some case reports that have supported that the transmission might have occurred during oral sex. I will say that in practice, we don't see this. And then there's proven no transmission from saliva or urine or feces or sweat or coughing or hugging, just as we know. So there are mitigating factors that dramatically change these risks, as I said, like particularly antiretroviral therapy or use of a condom, of course, but essentially there's a big variance in the risk of transmission of HIV depending on your exposure. Next slide. So, and this just highlights some data that, almost a surprise in medicine, which was that there were several different studies that monitored couples, and there had been couples studies previously where before the time of ART that showed that about 50% of transmissions were occurring in couples of all the transmissions of HIV. People who consider themselves either formally married or in a long-term relationship. And that's because you're having many more sexual acts with that person. And so if they have HIV, you're kind of asymptotically reaching their, whether they're virally suppressed or not or what their viral set point is in terms of risk. But then these studies, HBTN 052 and both the partner studies and opposite attract studies, ended up looking at couples depending on whether they had been virally suppressed or not. And what they both showed was there wasn't a single transmission from someone who was virally suppressed to their partners, whether it was heterosexual partnerships or among MSM. And over the past decade, there have been no HIV transmissions from virally suppressed persons with HIV that have been documented in the scientific literature. So that really led to a movement that came from the community that people who are virally suppressed do not transmit HIV to their sexual partners, or U equals U, undetectable equals untransmittable. And I think this means a lot for patients. It really kind of empowers them to know that they are not infectious as long as they take their medicine. And it's also been a result of a major kind of tool for us for prevention is helping people get diagnosed and virally suppressed. It also mitigates the risks, as I was saying, but most of the laws, the HIV transmission exposure laws that are in place don't take into account whether the person's taking ART or not. Next slide. So we did a study just to say kind of an ecological analysis of mathematical modeling over time, just to say, well, if these laws were put into place because you thought they would have a public health effect rather than being just what I wanted to do for other reasons, we wanted to know, well, did it work? So we looked at HIV diagnoses over time using generalizing estimating equations and a multivariable linear regression model that ended up kind of incorporating time. So if a state put in the laws, we then would look over time to see if it made any difference in terms of HIV diagnoses over time. And that allowed us to have 30 states that enacted criminalization laws at some point, 20 states that didn't. And we were able to look at other factors at the state level, like urbanicity, unemployment, low education, race, and ethnicity. Those were all associated with HIV and AIDS diagnosis rates. But there was absolutely no association between HIV or AIDS diagnosis rates and criminal exposure laws across states over time. And to some extent, that just makes sense, right? When they've done surveys, most people with HIV don't even know that these laws exist. So it probably has no effect on their behavior. But it also is helpful to know that at least that argument that it might be beneficial is not there. Next slide, please. And then I just want to highlight that there are 9 states that have laws that provide defenses for people based on scientific evidence, like they took practical means to prevent transmission, they were virally suppressed, or they used a condom, but you can see it's very few. Next slide. So I wanted to just highlight some of the modernization examples that could be put into place and that are being done in some states right now. One is that is just to make sure that HIV is just one of the things that are rolled into your statutes about general infectious or communicable diseases, rather than have specific laws that essentially are considered discrimination against people with HIV versus other infections. You can require an intent to transmit. You can provide defenses for people with HIV who took practical measures, like they were virally suppressed on ART or they used a condom. You can require HIV transmission rather than just exposure in order to apply a sentence enhancement for sex offenses. You can no longer criminalize oral sex, and you can provide viral suppression, again, as a defense that can be used by people who are being brought on these charges. Next slide. So I also want to just highlight that we thought we were making a huge difference when we started to try to change the laws themselves. But and sometimes those laws, those HIV specific laws, are being used. But it turns out that the communicable disease laws are also used sometimes. And so, and especially they're used for people who are suspected of committing a crime, and they'll be either threatened to have an increase in if they don't plea bargain, or they'll have sentence enhancements. So if you're going for a crime for 2 years, it becomes 4 or 5 years. And then I also wanted to highlight that these laws disproportionately are enforced in certain counties and by specific law enforcement agencies. If you map where they're being applied, and it's very hard to do this, but the Williams Institute and others have actually spent a lot of time analyzing this, you'll find it's sometimes just one DA or prosecutor in a particular city that is actually applying these laws. And reaching out to them and trying to talk to them about the science can be very effective in changing their practical application of these laws, even if you're not changing the law's existence in the first place. Next slide. So we're very interested in kind of either eliminating these laws and aligning all of the laws and their application with the current science, so that we don't have continued disparities in HIV that have plagued us from the beginning of the epidemic. And we have a kind of a legal and policy assessment toolkit online that people can use. And we have information and fact sheets that can be printed out if it helps to have CDC's imprimatur on this kind of information. Next slide. So now I'm ready for questions and comments.
Thank you so much. I was trying to figure out how to clear that image, so I think I was a little distracted at the end. I apologize. I think the idea, everyone, is please. I think you want to clear your screen. Oh, it's gone now. Maybe people can. We can get us into. Sorry, I have the wrong view. I was hoping people could turn on their cameras and we can have a dialogue. I see a question. Thanks, Dan. Thanks, Dan. I don't know what you did. Nettie Aldis. Nettie, do you want to unmute yourself? And I'd love for people to come on and actually have a dialogue if you're able to.
You could even take down the slide.
Yeah,
that's okay.
Yeah, I think Marvin, can we stop? Wonderful.
Great, thanks.
Beautiful. Here we go. We're all here now. Yeah, Nettie, go ahead.
Oh, I was just wondering. Thank you so much. That was fascinating. It was so great that I took it from the car and just snapped a bunch of photos. So really helpful. And I was wondering if anyone knows the status of California. I'm not up on this in California. It's not something that I necessarily advise patients about. and we've sort of changed, when I first got into HIV a long time ago, we talk a lot about trying to get patients to disclose and talking about disclosure and with U equals U, and we're really mostly focused on getting people undetectable and then advising that they live their lives as they wish. And so I'd like to know where California law, whether it meets or does not agree with my guidance.
Right. So thank you. So Nidhi, California doesn't have any specific HIV criminalization laws, but they can use other communicable disease or infectious disease statutes. So we're still left with an occasional prosecutors kind of using those laws. But to really deal with that as a state, it will entail mapping out where the cases are occurring and then probably going individually to those law enforcement individuals and talking with them. And it sounds kind of hand-on, but it really is probably down to that individual engagements. And I don't know currently what's happening, where that's happening in California, but I think the Williams Institute might have those data.
I think we should push a lot more towards broad advertising of U equals U beyond the HIV community. Mm-hmm. So we tell our patients that it's very empowering for the patients. It's, a big leap in mental comfort with your diagnosis, that that you're not a danger to anyone or to, but I think we should be pushing the U equals U message like out onto billboards for the general public so that everyone knows that and therefore can kind of shift their thinking, because a lot of this comes from people outside the HIV community who just are, ignorant to the current status of U equals U and HIV treatment.
Yeah, thank you.
Nettie, and I'll let Joel go in a second. Maybe instead of a billboard in Hillcrest that says "La syphilis es grave" with less ocular syphilis es grave with scary eyes on it, that makes me very frightened as I drive to work every day. We have things that say U equals U and other empowering messages. Sorry, anyone from AHF on the line? Maybe we can talk to some people about that. You would have seen that, Jonathan, if you were in person.
I know I would, and I would have reacted. And I do believe that congenital syphilis is grave. It's the issue that's interesting is that health communications science has shown that if you just scare people, they're actually more likely to do what they were already doing or not doing. But if you scare people and then you have an action step, it can be useful, right? So you want to be able to make sure that so Jill's driving around and tries to, right, if you put your head, but if they changed it to say, actually take a left and you can, pick up some bicillin.
Right. Thanks. Joel, go ahead.
Hi, John. That was great talk. Thank you. I'm glad we were all able to attend today. My concern, unsurprisingly, is about the public health data side of things, specifically molecular epi, but not exclusively. And a lot of the jurisdictions that I've worked with over the years have specific laws preventing public health agencies from sharing data with law enforcement. That's local law enforcement, federal law enforcement. New York City has some great public health protection laws. Those data cannot be shared even under subpoena, so we assume. And also at the federal level, I know that CDC has those protections through the assurance of confidentiality, which is great. But I do know that there are specific states, and I was recently informed of some laws in Missouri, which basically encourage the sharing of data with law enforcement. And I think that that's problematic, not just from the molecular epi standpoint, but also just reported viral loads, which could be used to say, no, this person had a blip, or this person was unsuppressed during this period. And I'm wondering, is there any concerted federal effort to help states revise the laws about the sharing of data that must be reported to public health for public health purposes and keeping them out of the hands of law enforcement?
So Joel, I'm glad you're on the case. So the answer is yes. We've issued a new funding, what we call a NOFO, to state health departments. And in that, we've strengthened some of the recommendations about all of these issues and some others. I did want to highlight that there's never been a breach of molecular epi data that we know of. And for folks, that's that when someone's been diagnosed with HIV, their blood is drawn for antiviral resistance. The poll sequences from that so it's just data is collected by the state through protected measures, and then with no identifiable information, a CDC system can then look and see where there are clusters occurring. And we've done a lot of important work showing that the state level actually and at the federal level that when you identify a cluster through genetic associations, that it's growing at about 10 times faster than other kind of cases, and we've had successes in going to those communities and not only bringing in HIV testing, which might not have existed, but actually sometimes bringing treatment that didn't exist locally, as well as kind of information about prevention. So whether it's a Latino MSM in Houston, or it's been groups in Atlanta, we've had good success. So I think there's an important public health tool here, which is similar to like what we do with a bunch of other infections. But it's this question of how do you, so I guess you want to have those protections in place. I would say, Joel, that where I think people sometimes bring up the issue of the molecular epi is actually not the surveillance system. It's actually what's happening is a case occurs, someone accuses someone of giving them HIV, and then what they do is they draw blood. That law enforcement can draw blood from both people to see if there's an association, and that is a totally different world outside of kind of the public health world, and that's where you start seeing this. No, you really did, and the problem is the science has advanced to the stage where it's not 100%, but it's pretty clear that you may not know if they went to one person and then went to another person, but you can show that those viruses are close enough that they are in a sexual network, and so I think that's where we are seeing some of those kind of cases that are coming up. I will say that what we're talking about here, though, is more like what you suggested, which is the vast majority of these cases are not where transmissions occurred. It's just where exposures occurred, and so people are concerned and sometimes have psychological concern. It's tough to feel for some people, and so those are issues, and then that comes into the court case. So I appreciate you bringing that up.
Thanks.
Anik, go ahead.
Thank you, Jill. Thank you for a great talk. That was really a really great overview. I was wondering about broader laws that increase HIV susceptibility. So, for example, laws that limit housing aid for people with a criminal record. And so that if you've been in jail or in prison, it's less likely that you'll get housing support and that it's more likely that you'll end up homeless. And does the CDC have any involvement in potentially modifying those laws?
So, Anik, that's the first time I've heard of that. I didn't know that was there. I do know that so I would say that I'm interested in what you said and seeing, but I do know that it is a very big issue. The overlap of justice-involved populations and people with HIV and hepatitis C and syphilis and gonorrhea. I mean, it's much more likely. Doing screening and other kinds of support services in jails and prisons is one of our big efforts. We want to work with across the criminal justice system to be able to bring public health and healthcare rather than the opposite. But what you're saying is true, and I don't know if HOPWA, which is the HUD's program specifically for housing for people with HIV, has those same restrictions. And so when we get off the call, I'm going to look it up. But I think that there are a lot of concerns about different kind of environmental factors that have resulted in exacerbated both transmission as well as worsening access to healthcare. I would say one of some of them is what you're talking about. Others are things like Medicaid expansion. There's been data to show if you didn't expand Medicaid, you're more likely that people with HIV die, right? That's not nothing. That's a real outcome. It's hard to find an outcome stronger than mortality or survival, and it's there. So there's a lot of interest in CDC to think about this, and so we actually have not only have a whole modeling engagements with 3 different universities where we're working on how to look at some of those ecological questions that, like what I presented earlier, but also we with Change Lab, which is a group in San Francisco to try to actually do training, and we do work with the National Governors Association and the National Association of State Legislatures to have these learning labs where we come together on specific topics like student service programs and talk to them and have different parts of the government together. And we play as like the dispassionate information provider. So we're like, yes, you want to know about SSPs, we will do it. These are what you can do. And those have been relatively productive, but they take a while for each state. But we've seen results. So I'm going to look up what the specific thing you raised, but I do think we're very interested in kind of changing those higher level policies.
Thank you. I added a thing that's very specific to San Diego, but it's basically they're trying to change that in San Diego. Open to public, yes.
Great.
Public.
So I believe that there might be specific felonies that are restrictive. I think arson and a sexual assault charge tend to be the two that really, prohibit people from getting into housing. And I think it's because it's a communal setting that those are the two main problematic charges.
Not homicide?
That one hasn't come up yet, Jill.
I guess we're softer on that. No, okay. Thanks, Courtney, for the info.
I did notice something in the chat. Can I ask about the chat stuff, Jill?
I'm so sorry. What did I miss?
No, there's a question from Jeff Taylor, or a comment from Jeff Taylor. Wait. He's just coming to. There was someone who said, Aaron Wilcott, who I can't see.
Yes, I thought we were sort of addressing it. I can read the question for those who don't see. About opt-out. Yeah, so state laws requiring opt-out HIV testing also contribute to stigma and reduced ability to test for HIV. Any work happening in Sacramento, I assume also at the federal level, to improve those antiquated laws.
So I guess I don't fully understand the question. I thought, opt-out HIV screening and hepatitis C screening were put into place to decrease stigma and have been very effective at doing that. Because instead of having to ask people, tell me more about who you're having sex with and what kind of sex did you have and all that, we just routinely say, by usually things like age, that everyone should be screened. And my understanding, and I have a slide on this, that at least from a couple of places like New York State that put in laws that said every time someone comes to a hospital setting, they should get an HIV or Hep C test, which, by the way, we would not recommend every time. That's not in our guidelines. But that those screening activities have been highly productive and cost saving. And in fact, especially when you link people quickly. So at least the concept that we are routinizing and normalizing HIV, just so it's just like you're screening for a hemoglobin A1C to see if someone has diabetes, or even a blood pressure check to see if they have hypertension. It would be better for us as a society if HIV were normalized that way. Now, because it's ensconced in the social environment that it is, it will never be quite the same. STIs are always somewhat stigmatized, but I would love to see it more normalized. And so I would love to know if there's a specific area in California, or some topic for laws in California that I'm missing. But I don't know of anything in California that has struck me as being has come up before.
Yeah, Aaron, do you want to unmute and maybe clarify what you were saying? There we go.
Yeah,
Aaron.
thank you. Thank you for the presentation. I'll kind of explain where I was coming at with that, the question. One of the issues that I have discussed with other providers in our healthcare system is that in California, if someone's going to order an HIV test, we have to consent the patient, which is different than ordering a hemoglobin A1C test with the patient. And I think that creates, if somebody who doesn't do that regularly is not versed in that when in like a primary care setting. And then also it does sort of exceptionalize the HIV screening process apart from cholesterol screening or something like that. My understanding is that that law came from the implications of having an HIV diagnosis, which was things like life insurance policies, being able to purchase health insurance before the Affordable Care Act. And I really think that a lot of the laws in the Affordable Care Act, which now cover HIV screening completely as part of preventive health plans, and require health insurance coverage regardless of diagnoses and things like that. And yet we still have these laws that require, at least California does, that require counseling and all these extra things around it, which we don't do for a lot of other blood tests and screening things that we do, syphilis testing, et cetera, et cetera.
Aaron, thank you so much. This is really helpful to have the clarification. I would say yes. Even in outside the clinical setting, right, where I will call it testing. So people have some demographic or behavioral risk that's putting them at risk. We talk to them, right? There's a benefit, and it tends to be more special. In the clinical setting, the 2006 CDC guidance, and we are updating it, it was a revolution because it recommended that in the clinical setting, you should do this opt-out thing. And you just say to people, we test everybody. And so we're, unless you object, we're going to test you. I agree with you that that is not ideal. First, because you're still contacting the patient. It's still exceptionalizing, and people get confused and think they might have to counsel them, even if it's not, right? Because again, if someone has a risk, if in their, if they are hospitalized with subacute bacterial endocarditis, you should be doing an HIV test, and you should be getting them some substance use treatment if they're ready for it, or no, and handing them naloxone along with their toothbrush when they leave the hospital. I mean, we should be doing that. But so one of the things that we've been very interested in and has been going on, actually, I will say nationwide in many different communities, is standing orders. So this is where your laboratory has a standing order that if the EHR doesn't have an HIV test already on record and it's automatized, then it's added on when you get your cholesterol check or something else. And you can have restrictions by age, you can do whatever you want, and then we still have an out that says, if you're not getting any positive, stop. But if you are, it's been hugely productive because look, first of all, I don't want the clinical decision tool asking me something else. How many do we have to ignore? That just adds another one that I get to ignore. No, I want to be able to say that a result comes back. It's negative. Okay, 8% has an HIV negative. Oh, there's a positive here. I should react to that and meet with the person. So I really like your point that there's this zone where opt-out is it's better than opt-in, but it's not quite standing order, routine normalization, and I think that will be our future. That's now interestingly, we're going to have some out because there are a lot of hospital systems in the United States where it's not effective to do HIV screening or Hep C screening or even syphilis screening, but there are a lot that are, and so they're going to need to say, how's it working? Like, is it as a hospital community, is this worth my doing? Am I finding people or not? But I like your question. Thanks.
I will just argue again. I totally agree with Aaron. I want Chadwick Campbell has been trying to raise his hand, so I'll let him go. I will say when we order labs for patients, I think the way that we're supposed to do it is say, here are the labs that I'm going to be getting today. And you should be asking if they want an A1C. You should be asking if they want a cholesterol test. I don't think those are things we're just doing without their permission. I agree, though, the way that we frame it, and then, of course, everything that Adam Bortner just put in the chat about information about the test, informing what it means, what the test is. That's very different than what we do for the rest of them. But I do think we should be getting permission for anything we're doing. And when we don't, we do, why did you run that extra cholesterol for me this year? I definitely have that occasionally. Anyway, Chadwick, would you like to ask the last question, have the last word? I know it's 9 o'clock, so we'll be fast.
Yeah, I'll be really quick. Dr. Mermin, that was a really interesting talk. HIV criminalization is something that I have been very interested in for a long time. And forgive me if you said it, but one other thing I wanted to just add is that in some states, these laws are not just about exposure, but disclosure or non-disclosure, right? And so one of the things that I've written about and that I've heard from in my qualitative work, particularly in the South, is that it has this chilling effect because people are afraid that they will be accused of not disclosing because the relationship ended badly or because someone's just being vindictive. And so I'm wondering to what extent that has been a part of the conversations that you all are having, sort of this way that these laws are used socially as sort of a weapon.
No, thank you so much. I didn't mention, but it's absolutely true. It's everything you're saying is being experienced. And that's what hurts the most sometimes, is when you come down and you meet with and talk to someone, and you see what they went through in a relationship that didn't have to occur. Like, relationship breakups can be bad. They didn't have to have this, right? And I agree that those are that is still a major issue, and it's not that's not going to be picked up in your review of cases, right? Criminal cases, because it didn't even get there. It was just a power dynamic or something else in the relationship. And you can get threats, you can get other things. And so I agree, it's another benefit, certainly, of the HIV specific criminalization laws, because a lot of that would go away with just eliminating them. I also didn't understand that San Diego was southern US. It's Southern California, but, or do you actually
No,
travel to my part of the country?
I am from Louisiana, and so I have done some research in Louisiana and in Texas. I was not talking about San Diego.
But sometimes, no.
Sometimes.
Yes, I also do work in San Diego, of course.
Well, I do want to respect the hour. Dr. Mermin, thank you so much. I know we were very persistent. I actually think we wanted you here in 2020 even.
Yeah.
So, we work hard to get what we want. And I think this was great and such a thoughtful dialogue. Thank you so much. We will have to have you out here at some point. So we'll figure out when that is in the future.
Great. Well, thank you, everyone. It's just a fantastic discussion, and I appreciate all the work you're doing. Take care. Thanks, Jill.
Bye, everybody. Have a great weekend.